Welcome to Behind the Eyes. My name's Adam and I'm joined today by Mat Roney, the clinical lead optometrist for acute ophthalmology at the Royal Liverpool University Hospital Trust. Matt, how are you doing?
Yeah, I'm great. Thanks so much for having me. It's an absolute pleasure to be here.
Thank you for coming in. I really appreciate you coming in. So you're a hospital optometrist. Let's just get it out there, hospital optometrist.
Yeah, hospital through and through.
Yeah, and that's the reason why we've got you in, to talk about that journey, talk about why you do it, talk about what you get out of it, talk about how you got to a place where you are now, because I've seen you several times for the LOC. You keep on, your clinical responsibilities keep on growing, okay, and that must be down to being in hospitals as well, okay. So we're going to look at that and hopefully get some key learnings from that as well, similar hopefully to what we've got from our previous guests. All right, okay, so that's absolutely great. So start with your brief career history. Where did you start, and what do you do first of all?
Yeah, for sure. So grew up in Newcastle and then ended up doing optometry at the University of Bradford.
Yeah.
Really enjoyed it. And, I was really guided by some key mentors there, in particular Ed Mallon. Really kind of pushed me hard, made sure that I was getting to where I want to be. And for me, I ended up doing my pre-registration training at Moorfields Eye Hospital in London.
Wow. Okay.
So I was really fortunate.
The place to be, yeah.
For sure. And, I still stand by that. I'm really fortuitous to have been there. And anyone who has the opportunity to work there, I would highly recommend it. It's a great place to work. And I did a year there, essentially completed my pre-reg there, and then I went for a higher grade job there. And unfortunately, I was unsuccessful, and I looked at other places. And Liverpool was one of the places that also were advertising. So I went there, and I thought, this is a backup for me.
It's a big city.
Yeah, exactly. And it was a big move as well. Going from Newcastle to London. I don't have any family in Liverpool, so real big move for me. And essentially, I had the interview, I got offered the job, and I loved it. It was great.
Good.
And really, the intention was that I was going to stay for a year, and then I was going to go back to London. But I enjoyed it that much that I ended up saying, this is great, really enjoy it. Let's stay where we are. But my contract at the Liverpool Royal was only for 12 months. And I got to the end of the 12 months and there was unfortunately nothing there for me. And that's unfortunately some of the downsides with hospital optometry. So that sometimes you come in with a fixed contract.
Contract work, yeah.
And
that's just the way the NHS works sometimes.
Exactly.
For financing or budgeting, isn't it?
Exactly.
Yeah.
And I got to the end and there was nothing there for me afterwards. So I had to look further afield. And Alderhay Children's Hospital, so just down the road, were advertising for a senior optometrist. And, I put my name in thinking, it's not going to work out.
Normally 2-3 years?
Yeah, typically, 2-3 years, you start looking for a higher post. But I was really, at that point in time, really wanting to stay in Liverpool. And I put my name in and I was really fortuitous to get it. And I went to Alderhay for 12 months. And, it's a great team there. Really enjoyed working there. Some great colleagues that I have there still even to this day. But pediatric ophthalmology and pediatric optometry was just not for me. It wasn't what I enjoyed.
Was it too mundane, was it? Or not saying challenging, because there's different communication skills you need. But
I think for me, the problem with pediatric optometry is so that it's so broad and it requires such an MDT approach, in a sense that once you get into the hospital, looking at these children who have got these weird and wonderful pathologies.
MDT, multidisciplinary team.
Exactly.
Okay, jargon. That's fine.
Sorry, apologies. Multidisciplinary team.
No, I've learned that one today. That's fine.
So you've got people like cardiologists coming in. You've got neurologists. You've got ocular orbit specialists, so oculoplastic teams. And for me, it was just at a point whereby I didn't feel as though I could be specialized in that area. And therefore I looked back and I said, what did I really enjoy when I was doing my pre-registration training? And one thing that I really enjoyed was glaucoma.
Yep.
Now, after that, fortuitously, another job came up at the Liverpool Royal, which was a substantive post. So it meant that it was permanent and it wasn't for a short period of time. So I ended up switching back and I went back as a specialist optometrist in glaucoma and medical retina. And I worked as that for about 5 or 6 years. And then I did some higher qualifications, which we can talk about if you want.
Well, can we just talk about those now?
Sure,
Because
please, yeah.
a quick recap. So you've been qualified for 1 or 2 years, older hay,
Perfect.
and now you've decided to move to the Royal for back to Royal for as a permanent post. Or
Yeah, so it was a permanent post back then. Yeah.
And tell me about these higher qualifications that you've done.
Yeah, so I ended up, when I went back to the Royal, I thought, I really want to be involved in glaucoma. I really enjoy it. I think it's such a really interesting subspecialty, especially within optometry. And I thought, how can I support my learning? How can I further it? Because I think you've got two types of learning. You've got anecdotal learning, so the patients that you see every single day, and you learn from that. That patient I have a gut feeling about. I've tried it like this before, and this is typically how it goes.
Experience,
exactly.
Yeah.
And then you've got formal learning. Learning textbooks, reading literature, journals, etc., etc. So I ended up deciding to do the higher qualifications through the College of Optometrists in glaucoma. So I did the professional certificate, and I got to the end of that.
Yep.
And then I thought, you know what? I'll do some more. So I did the higher certificate in glaucoma, and I got to the end of that. And then I decided that I want to do independent prescribing, because constantly I was ready to give prescriptions to patients with glaucoma. And every single time I'd have to go to a doctor and say, can you just give me a prescription for some latanoprost? And for me,
just like that. You said just like that.
Just as easy as that.
But yes, but I think just to kind of extrapolate a little bit there. You said that in 3 sentences. I did Prof Cert Glock, did higher Cert Glock.
Yeah.
These were funded by the hospital.
So actually, no, these weren't funded by the hospital.
Okay, fine. So it's important to delineate that, because I assume they would be. Some viewers or listeners would actually assume they would, but they're not. Or are they sometimes, or did it depend?
Sometimes. It really depends upon where you work.
Right, okay, fine.
And the experiences that I give today on this podcast are not truly representative of other trusts and other hospitals.
We're not saying this is carte blanche NHS.
So I have some friends who have done independent prescribing, for instance, and it's been funded by the trust. Now, my professional certificate and my high certificate in glaucoma were self-funded.
Yeah.
My independent prescribing, because I started working in A&E at that point in time, and I moved from the medical retina side of things to A&E, the trust ended up saying, that's really useful for A&E, we'll fund you to do that. So they funded my independent prescribing. And at the same time, because I thought it'd be such a great idea, I ended up doing the diploma in glaucoma at the same time.
Tough.
Really tough, yeah. But they went hand in hand.
Right.
Independent prescribing with the diploma in glaucoma, it was all about steroid use, antibiotics, post-operative care, listing for surgery, lots and lots of things where the IP came really into play there. Yeah. So yeah, really useful.
So you got a big badge.
Yeah, big badge. I maybe should talk a bit more about it. So
you got a lot of letters.
A lot of work.
So you're in the glass. I remember doing my IP, and I saw you in a local clinic in Garston.
And that's where we first met. Actually, all those years ago. And
there's 2 optometrists, maybe 3, and then you're all seeing the patients that we referred in or being triaged, or you are monitoring existing stable glaucoma patients, and there's the consultant who I was sat with mainly, who was, you were asking questions if you weren't sure, but he was basically delegating that under his supervision. So that's how. So that was about, believe it or not, 7-8 years ago.
It was, that was back 2016, 2017, wasn't it?
That's pre-pandemic. Okay, so you've got so at that point had your diploma in glaucoma, did you?
So I got my diploma in glaucoma in about 2021.
So that's later. So we were working towards that.
Yeah. So when we first met in 2017, I was newly qualified.
Right. Okay.
I think at that point in time I was starting to put my name in for the professional certificate.
Right.
In glaucoma.
Okay.
So
fine.
really at the start.
Okay, at the beginning. Okay. But I didn't realize at the beginning. Okay. Fine. So that was post pandemic. What's your clinics? What you're doing there in terms of the hospital? What you're doing there?
Yeah, so post-pandemic, completed the diploma in glaucoma, and really that pushed me forward in the glaucoma clinic. Ended up taking a lot more responsibility, looking after post-ops, patients who have had trabeculectomies, cataract surgery combined with stents, so like an eye stent or a hydrus, gave me a lot more autonomy. And now to this day, you know, I work in collaboration with some really great doctors, some really great optometrists. But I think, you know, a lot of cases I manage independently. And a lot of the conversations that I do have are kind of, you know, what do you think? Where do we go forward from here? But there are plenty of instances whereby I go, I just don't know. I need some extra advice, and that's what my consultant and my fellows, and my consultant and the fellow is there to provide that support. But you know, doing a lot of high risk glaucoma stuff, looking after really bad glaucoma, lots of aggressive pressures, plenty of tubes, trabeculectomies, things like that.
So, aggressive pressures. You know, I've not heard that term before. Rather, don't want to be too clinical, but you know, that means basically high pressure over 24 just won't come down at all.
Exactly.
Right?
So one case that particularly sticks in my mind when I was doing my diploma in glaucoma, there was a gentleman who I saw, and essentially he was on a lot of treatment to try and control his pressure.
Yeah.
His optic nerve was really, really poorly. It was really damaged, and his field was really poor as well. He was on lots of medications, and his pressure was 45.
Wow.
You know, so really, really bad scenario, unfortunately, for the patient.
I just prefer that. I prefer that back.
It just needs seeing. But that's what I mean by aggressive pressures, you know, pressures that are just medically uncontrolled, resulting in progressive damage to the eye. And really, those kinds of cases need strong and fast intervention.
Okay, fine. So you are, and you have done, you're doing it not just the qualifications though. You've used them to actually be all due respect, like a bit of a mini eye doctor, really. You've done. I'm quite sure you've done some laser work. And things like. So what have you done there then?
Yeah. So laser's been something that we at Liverpool have just moved into.
Yeah.
So within kind of the last 12 months or so, and me and my colleagues as optometrists were undertaking some of the more routine work within ophthalmology. And I think, you know, one thing to say is that we're certainly not in replacement of ophthalmologists. We're an adjunction to support and.
But the fact you're doing it, the fact you're in that conversation is. It's miles away from where we were, you know, when I first qualified. So yeah,
exactly. You know, things have changed a lot in the last 10 years.
So what exactly are you doing laser-wise?
Yeah, so I'm doing posterior capsulotomies, so after cataract surgery.
Yeah.
I've done some peripheral iridotomies as well for raised pressure. I've done some SLT, and I've also done a couple of cases of retinopexy. So for retinal tears and for proliferative diabetic retinopathy and for vein occlusions, I've done some PRP there as well.
So you've done PRP, right? Okay, all right. So you've gowned up and you've done all the bits, and you're at the eyepiece.
Sitting at the microscope now and playing Space Invaders, you know.
Okay, yeah. We might edit that bit out. I'm not too sure. No, but I agree. So that's pretty intense. There is that. And is that the exception that proves the rule that most optometrists don't do that? Are you lucky to do that, or do you think that's just your hard work that's got you to do that, or does every optometrist have the opportunity to do one or several of those things? I have heard some people doing SLT before. I've not heard of the retinal stuff. So what's the take on that?
Yeah, I think I have to be honest with you. I don't think it's going to be for everyone. To be perfectly honest, when I talk to colleagues up and down the country, you know, I've got connections from the south all the way up to the north, and I have some colleagues who are doing retinopexies, who are doing injections to the eyes. You know, so I think it's an ever-evolving space. But do I think that it'll be for every optometrist, and do I think it'll be core fundamental skills? Probably not, to be honest. But I think for a particular cohort that have got the right level of training, right level of supervision, I think they have the opportunity. There will be the opportunity to kind of move into this space going forward. Okay,
wow. So some very, very intense clinical opportunities there for you. You know, to really get hands on. You know, all due respect. You know, you aren't just looking at a visual field and doing a set-up assessment and disc assessment and going to your consultants anymore. You're actually doing it in the firing line, basically. Yeah.
And I think that's the thing, is that when you start to move into these areas of minor procedures, you need to kind of take that responsibility. For instance, I saw a patient the other day who is essentially, she's only got one eye, unfortunately, because the other eye, unfortunately, is blind from glaucoma. She came into clinic and she said, my vision's just not feeling great at the moment in my good eye. And, I had a little look at her, dilated her up, and she's got moderate PCO. And I was really fortuitous in a sense that there was the laser clinic that was going on in the morning had finished, took her down, put some more drops in, and ended up doing the
Bish, bash, bosh.
Wow,
and
she benefited significantly
from it. Yeah. So that's real. That's real, isn't it? Come in, I'll give you a laser. That's pinnacle in my opinion.
For sure. And I think it's just about, it's trying to see the other side of the fence. I'm sure plenty of community optometrists in primary care refer for YAG laser, and in some cases they don't hear anything back. Your patient may never come back to you.
But they can see. So yes.
But for me, I'm really fortuitous in a sense that I can be on the other side of the fence and be able to provide that kind of care. But the one thing that I really like to do is try and get back in touch with primary care. If I've got a community optometrist that I can write to, I'll always try and write back to them to kind of say, this is the lay of the land. This is what we've done. Because I think it's about that communication side of things.
So nowadays, this is the glaucoma clinic that you were in. You've got all this experience, which is, top level stuff, really. What are you up to now? What's your role at the moment?
Yeah, so a couple of months ago, I was really fortuitous to be.
You say fortuitous, and you said it about 6 times. But I have to say, you could, unless you have a lucky rabbit's foot in your pocket, you must be a hard work that gets you there. I think that's all, because we had other podcast with peers of yours, and similar, they progress up the chain.
Yeah.
It's hard work.
It's hard. It's work. Yeah, and
you don't just get these opportunities. You got to,
You've got true. You've got to kind of you've got to put the hard graft in to get the rewards. Yeah. But I'm always, I'm very appreciative of the opportunities that I've been given, and I think, would I be where I am without particular people pushing me in the right directions? And that's what I probably mean more by being fortuitous, in a sense that I've had the right guidance, the right mentorship. You have
to be in the right place, right time. But sometimes you have to put yourself in the right place in the first place. Exactly. It all has to fit in.
Exactly. Things happen for a reason.
Yeah.
If you don't get a job one day and you get something different further down the line, things happen for a reason. So
I dragged you off piece. I'm sorry. So what's your
So now my main title is I'm clinical lead optometrist for acute ophthalmology.
Yep.
So I'm the lead optometrist working in A&E.
Okay.
Which is a real great role.
Which is different.
Completely.
Glaucoma is, all due respect, a long chronic progressive condition. So what you're doing is in the front line, effectively.
Yeah, exactly. So essentially my working week is split into 3 main parts.
Okay.
Glaucoma, working in A&E, and then also doing some research as a PhD scholar as well.
Right, okay. Even more letters.
Trying to get those letters.
Another badge. You need 2 badges.
Maybe you need to do double lines or something like that.
And then you'd be Dr. Roney.
So Dr. Roney, that'd be a nice title.
Yes.
But I think one thing I've got to say is it's a title that has to be used with, how can I describe it? A bit of careful due diligence, in a sense that, you have to be very clear in a hospital who is who. Who's
a doctor? Okay.
Exactly. I'm not a medical doctor. I'm an academic doctor.
You're doing some doctory stuff,
and I think that's the point, that you have to be very clear with patients.
Of course,
My name is Matt. I'm an optometrist.
Yes, of course.
Nice to meet you. But yeah, A&E. So it's great. Really, really enjoy it. It's very much a wildfire. There's people here, there, and everywhere. You've got multiple patients on the go. You've got patients dilating, patients waiting for bloods, waiting for medic review. And when I say medic, sometimes I'm talking about ophthalmologist, but sometimes I'm talking about rheumatology, cardiology, general medics. Lots and lots of different subspecialties involved in that care.
So in terms of workload, okay, are we talking stress? No, stress is a very word commonly used, but obviously A&E, you imagine it being like gunfire. That's what you imagine. I have been in clinics where they're actually well run. They're actually, they're actually not. They're
Yeah.
actually, you see people, but it's a
sure.
flow, and they've already been triaged by a clinical
By a
practitioner,
yeah,
a nurse
exactly, by a
practitioner,
nurse,
who
yeah,
do an amazing job really doing foreign bodies and
Fantastic.
all the rest of it.
Exactly.
So yeah, there is that. But is it more stressful doing the A&E stuff? Is there definitely a difference where you kind of go, "Phew, I'm glad I'm in glaucomic on a Monday," is there, or what?
You know what? I think it's an enjoyable stress,
Right.
to be perfectly honest.
Okay.
I think it's you're going in, you don't know what's going to come through the door.
Right.
In a sense, at glaucoma clinic, the majority of patients have glaucoma. There's the odd, weird, and wonderful one there, in a sense of maybe they've had like a previous vascular event, so like a non-arteritic anterior-ischemic optic neuropathy.
Yep.
Whereas A&E, it can be anything. It could be an infection, could be a bacterial keratitis.
Yep.
It could be a detachment. It could be post-operative UV inflammation. It could be a huge variety of different things. But I think that's what I really enjoy about it. You have to sit down and you have to think, right, okay, well, this patient's coming with a red sore eye.
Yeah.
Where do I go forward from here? Where do I steer that ship? And it's very different to clinic. As I say, majority have got glaucoma. You treat the pressure. Pressure high, bring it down. Pressure low, you're fine.
True. So this kind of A&E role that you have at the moment, and even your glaucomas, I think obviously your diploma in glaucomas help with your glaucoma. Knowledge,
100%.
understanding, 100%. You can't.
100%.
It's obvious. It's
Exactly.
obvious.
It's really been instrumental to pushing me forward.
So what qualification has helped you with the A&E? Because, is it the med rep, noticing what AMD is, what different types are, your CMV or your CMO, all that kind of stuff?
Yeah, for sure.
Or is it the prescribing that was more helpful in terms of the red eyes stuff? What's been most helpful?
Yeah, I think for me, independent prescribing is a key thing, for all the optometrists that are working in A&E in Liverpool.
Yeah.
For me, I think that's where we need to be as
How
a starting
about
point.
community? What's your opinion on that from what you see? Do you think would your job be made easier if more community optoms in the region or any region had IP? Would that benefit not the hospital, because make your job easier, but it would get the right people seen at the right time?
Yeah, 100%. I talk a lot about getting the right care in a timely fashion, as close to home as possible.
Yeah.
And I think, for me, I say this openly on multiple occasions, that I'm not a community optometrist. I don't work in primary care. I am not good enough to work in primary care, in my opinion.
You say that yourself, would you?
And it's because I see them as rock stars. They know everything about anything. My wife is a community optometrist, and she's now working and doing some hospital work. And she comes home, she talks about stuff that, I just don't know about, because all the stuff that I see in hospital has come through the community
filtered
optometrist.
Gone through the system, yeah.
Exactly. And it's stuff that needs a second opinion, But I think going back to your question, would I recommend, I think ultimately the question is, would I recommend community and primary care optometrists to do IP? 100%. I think it's a really invaluable skill to have. But I think the other thing is that, to the best of my knowledge, if we take a slight turn down maybe a slightly darker path, but if we think about fitness to practice, from the best of my knowledge, according to the GOC, there has never been an independent prescribing optometrist put in front of the fitness to practice panel, which I think is if
you're putting it out there, you put it out there. I've not forced you to say it, so I didn't know that. So there you go.
And for me, that just says that independent prescribing optometrists have really taken that opportunity to commit to the profession and commit to their job to kind of work at that next level. And I think for me, when I did independent prescribing, and I teach independent prescribing at one of the universities, I see optometrists develop and come out with skills that really grow them and make them into better optometrists. Yeah, exactly. So I think for me, would I recommend primary care optometrists do IP? 100%.
And with regard to your job in A&E, you've used prescribing more, you think, than
100%.
Okay,
You know, the nurses are sick of me asking for an FP10, so a prescription for patients, because you give it out to a lot of patients. Patients have turned up to A&E because the community optometrist had a look at them. They've wrote a letter. They've said, this is the problem. They need treatment. IP has been instrumental for A&E.
So there's a few things going on politically as well, outside of the hospital, above the hospital, kind of for cataract surgery, a lot more politics in terms of a few weeks ago, referrals to independent service providers were stopped for 24 hours.
Yeah, for 24 hours. They're back on the cards now.
Back on the cards. But that just shows, and there's also, I've seen on LinkedIn, a new tariff kind of policy proposal where I think where independent service providers a cataract surgery, despite how complex, is one tariff, but actually making it a range of tariffs. So the more complex ones get greater. So you make it because there's a feeling that ISPs, although I don't agree with it, kind of there's cherry picking in a certain sense, but they do have a massive role in reducing that waiting list down. Now,
yeah, for sure.
Now, I know that's politics. I don't really want to kind of go on that, but do you, in terms of cataract, there's now dropless cataract surgery, and there's now bilateral cataract surgery.
Yeah.
What's your opinion on that, or what's your experience about that, rather, if you want to be controversial?
So that's really interesting. I think there are two things that are coming, that are getting talked about, that are coming into the spotlight. And I think for me,
it saves time. Time's money.
Exactly. And imagine Doris, who's 90 years old, who's got bilateral cataracts.
Bless her.
She has to get an ambulance crew to bring her to the hospital to have cataract surgery. Would it be better to do both eyes on the same day?
Yeah.
And I think ultimately for me, in Liverpool, we don't do so much of that.
Yeah.
We don't do so much dropless cataract surgery either, that I'm aware of. But I think for me, everything that we do should be underpinned by evidence-based research.
Yeah.
If the evidence says this and it's of benefit to the patient, then why wouldn't you? But I think it's a space to watch at this point in time. I don't have a huge amount of experience or know-how on it. Fine. But I think for now, the evidence will shine through whether it's of benefit or not of benefit. And I think whether you work as a NHS hospital optometrist or an independent service provider optometrist, I would act upon that evidence that's there.
But no, that's fair enough. I wasn't trying to provoke you there.
No, for sure.
We're just trying to get the future, but these things are on the horizon, aren't
they? Exactly. And I think it's all about giving the best patient care that we can give. Going back to Doris, if you can do both cataracts without needing any drops afterwards, then why wouldn't you? That it's such a...
The side effects of drops as well, aren't they?
Exactly. And, even, patients got rheumatoid arthritis, trying to get those drops in out of these tiny little bottles. If we can do dropless cataract surgery, then why not? But we need that evidence to support it. I think it's definitely watch this space. And I think we're just so blessed. We're able to sit on this sofa and talk about these possibilities. If you go back 10 years... 20 years, would we ever be
Dreamland stuff?
Exactly, it's dreamland things. So for me, I think watch this space, because I think there's going to be some real developments.
Okay. Now, that's kind of the recent. Now, AI has been talked about a lot in life.
For sure.
Accounting firms replacing, executives with AI and get chat bots and stuff. So, what is any engagement in that in NHS hospital optometry at the moment?
So I think AI, once again, we talk about all these things that are coming through, and I think AI is going to be a big player here. But for me, I see it almost as an adjunct in a sense that it's something that's in addition to what we do.
Okay.
I don't think AI can replace that gut feeling.
Okay.
When you look at a patient, you go, what, something doesn't sit quite right here. And I don't think AI is going to be able to replace this. And I talk about it quite a lot with colleagues about, if you take the core fundamental skills of being an optometrist, imagine you've got a patient with funny discs. I like talking about glaucoma. It's no surprise.
Yeah, fine. Is Doris, or Doris is okay now?
Doris is great.
Doris is
she's
fine.
had her cataract surgery. She's great.
Okay, fine,
I'll tell you what, let's move on to John.
John,
he's 65.
65, young.
He's young. And let's say, for instance, his pressure's 22.
Okay.
And you look at the disc and you think, that looks a bit funny.
22 is not considered high anymore.
Well, it's, 95.
It used to be 21, but now it's 24. From my understanding. So you obviously educated me now.
Yeah. So essentially normal pressure, based upon the data out there, it really is 10 to 21.
Yeah.
And that's for 95% of the patients out there. 95% will have pressures between 10 and 21.
Yeah.
The number of 24 comes into play when we think about ocular hypertension.
Yeah.
And basically that's based upon some of the landmark studies, particularly the ocular hypertension treatment study, which basically says that, if you've got ocular hypertension, so a raised pressure, but a normal optic nerve with an open anterior chamber, you should not really consider treating it until it's greater than 24.
Yeah.
Or 24 or greater. But if you've got glaucoma, for instance, you've got nerve damage with a pressure of 22, you need to treat that.
Yeah.
But going back to John. So let's say, for instance, John, he's got funny looking discs. And for me, you have to do those core fundamental examination skills. So, looking at the disc, looking at the pressure, taking a medical history, asking about key risk factors. So things like, do you have a family history of glaucoma? What medications do you take, et cetera, et cetera.
Yeah.
Looking at their field of vision. And then for me, they're the core skills, and checking pressure as well. Beyond that, using things like OCT and pachymetry and corneal hysteresis and all these kind of fancy different things, for me, are an adjunct.
Right.
They add to your core fundamental skills. And the reason why I'm saying this is because I think this is where AI will come into play. I think it will be a key adjunct, something in addition to your core fundamental skills. And as I say, it's because that gut feeling, I think, is really what sets us as healthcare practitioners from an AI algorithm.
Do you think AI will get better and
100%.
develop this gut, kind of a Westworld kind of develop a conscience, develop a gut to become almost as good as a human or just as good as a human? You know what I mean? Isn't that what
for sure
people are afraid of, this kind of,
Yeah, and I think that for optometrists, I think is one of the key
It's down the line. It's down the line.
Is,
we don't know how far, but you
know,
don't know how far because tech is,
Exactly. It's as you say, it's taking off massively. Even at the University of Liverpool, we have professors in AI healthcare who are specifically looking at how AI works into healthcare.
Yeah.
And I think for me, it's just going to grow and grow and grow.
Yeah, that's cool.
But do I think it'll ever replace us? I hope not, and
No.
I don't think so.
Not yet.
But I think, as I say, I think it's one of those key skills that will be used in addition to what we do as healthcare practitioners.
I see. So so nothing being used again. There's no AI model being used as a research yet, but we're talking about it, so it probably will happen.
Yeah,
so,
for sure. AI is not my strong point, but for what I know, particularly in optometry and ophthalmology within Liverpool, we're not really using AI at this point in time. But I've been involved with some conversations around, AI producing optic nerve head images, and for optometrists and ophthalmologists looking at them and grading them whether we think that they're glaucomatous or not. So I think it's a real smart cookie.
Yeah, of course.
And I think it'll be certainly something that we need to talk about more in the future.
Yeah, no, fair enough. So I was just wondering your opinion as a hospital, because I think personally from what I've seen in my own experience, refraction wise, I think something will happen there, in terms of, it'll become a lot easier, a lot quicker. Whether that will disrupt the model, I don't know really, to be honest with you. But it's soothsaying at the moment, but you never know what's around the corner. So yeah, it's tricky. So, we've had a good chat there about, everything that you're doing, and, fantastic career so far, loads of hands-on experience, loads of, nuggets there, using your IP, using your medret, and your hard work that backs it up. Okay, so but reflect back to the first uni qualified Mat Roney, you know, in 2017.
I looked a lot younger back then,
Well,
less wrinkles, you know.
Well, wait to hit 45. Then, you know, what 3 bits of advice would you give a newly qualified Mat Roney now?
Yeah, I think for me, I think advice that I would give back to myself is, for me, I would take the opportunities that you're presented with.
Yeah.
You know, I think that's a real good opportunity. You know, if you get the opportunity to go and do this, take it. I would always make informed decisions, you know, always having those conversations, always asking the questions. I'm a firm believer that an informed decision is a good decision.
Yep.
If you don't have those conversations, don't have that opportunity, then, you know, for me, it's not an informed decision.
Yep.
I think do what makes you happy, you know, and for some people out there, being an optometrist is coming in, doing your job and going home and having a family and doing this and doing that. For other people, you know, it's doing higher qualifications, doing a PhD, doing this, speaking at that, going to conferences, you know, and if that's for you, great, go for it. But it's not for everyone. And I think it's all about, I'm a firm believer of do what makes you happy. And if being an optometrist that comes in, works 9 till 5, Monday to Friday, which I think is the dream for some people, not having to work weekends as an optometrist, then go for it. But if it's going to conferences and trying to push yourself and do IP and things like that, go for it. And I would thoroughly encourage anyone, if you're interested in something, make it happen. If you want to be interested in medical retina, do a professional certificate or higher certificate in medical retina. If you're interested in glaucoma, go and do some glaucoma, you know.
Okay, fine. Really, really good. Okay. Thank you for coming in.
Oh, thank you so much for having me.
Thank you for
really
your time.
Appreciate it.
Thanks for the lessons there. No, I didn't realize you did that much in treatments there. But yes, loads of stuff going on. And I think it's worthwhile saying that you do keep in touch with stuff that goes on outside the end as well.
For sure. You know,
the LOC. You know, so
is
that, and you do that just to keep your finger on the pulse? And
yeah. So one of the roles that I have is I'm a council member for the College of Optometrists,
yes,
and I'm a trustee for the college as well. And for me, you know, sitting at the college table, I have to be representative of not only myself, not only representative of hospital optometrists where I work, representative of academics, but also of primary care optometrists. Because, you know, if we talk about the majority of optometrists in the UK, they are primary care optometrists. So for me, having that active involvement with the LOC and with colleagues like yourself, you know, networking is really, really important for me. Being able to be representative of the profession, not just of the inner circle that I have.
Yeah.
So yeah.
True. Matt, once again, thanks for coming in. Thank you. Great to talk to you.
Perfect. Thanks so much for having me.